In this section, we will be discussing about a very important topic called a myeloproliferative neoplasm. Like the terms myeloproliferative neoplasm, myelodysplastic syndrome, myelogenous leukemia, then a lot of overlap syndromes are there with it. Everything looks very similar and they are going to be very confusing as well. I told you very clearly there is something called a myeloid precursor cell or a myeloid progenitor cell. Let us assume it's a precursor. It's equivalent to the progenitor cell, the myeloid precursor cell, which has to differentiate further. It has to differentiate and mature further to produce the mature cells like neutrophils, granulocytes, other granulocytes, even your erythrocytes, thrombocytes. All these things has to, is produced from this myeloid precursor cell only. Suppose if there is a failure of differentiation, if there is a complete failure of differentiation, you know that this myeloid precursor cell are going to accumulate as something called blasts, and this is what we refer to as a leukemia. Everyone knows that. So it is the failure of differentiation. That's what we call a leukemia. Suppose the same myeloid precursor cell, let us assume due to some notable mutations, if the differentiation and maturation is actually happening in increased amounts, suppose, what's going to happen? Your terminal cells are going to increase, like granulocytes, your RBCs, all these things are going to increase. This is what we actually refer to as something called a myeloproliferative neoplasm. So you can see it is very different from what you see in leukemia. It's not the same process that is happening. Suppose if the same myeloid precursor cell is having some defective maturation, I'm not telling it's failed maturation, I'm telling it's still maturing, but there is some block, there is some defective maturation over here, it's trying to, because of this some mutation in the myeloid precursor, some damage to the myeloid precursor, there is a defective maturation. This defective maturation will lead to some abnormal cells, and the cells will look dysplastic, and this is what we refer to as something called a myelodysplastic syndrome. In this, the amount of mature cells again is going to reduce. Clear? At the same time, the precursor cells that are defective, the myeloid precursor cells that are defective, that are also going to get destroyed in the bone marrow itself. In the destroying the bone marrow itself, which means it's going to result in something called ineffective hematopoiesis, because they try to differentiate but they can't, but they are defective differentiation and maturation, and that will be destroyed within the bone marrow, and that might result in ineffective hematopoiesis, and hence you might result in reduced number of cells in the periphery. So you can see all these three processes are totally different. If you have a complete failure of maturation and differentiation, you are going to increase in the number of precursor cells, blasts, and that's what we call leukemia. If there is increased differentiation and maturation due to some mutation, that's called a myeloproliferative neoplasm. And if there is a defective maturation but not a totally failed maturation, and if because of that you are going to have this kind of dysplastic cells that you can see that are circulating in the peripheral blood, and that's what we are going to call it as something called a myelodysplastic syndrome. To understand what is this to put all these things into perspective, let us put this kind of Venn diagram like related thing. So where you can see this spectrum, we can call it as something called myeloproliferative neoplasm. Maybe this we can call it as a myelodysplastic syndrome spectrum, and this we put as a overlap syndrome maybe. So let us assume this is a myeloproliferative neoplasm and this is a myelodysplastic syndrome, and there are a lot of overlap syndromes, a lot of other, but we are going to discuss only two in general. So what are the myeloproliferative neoplasms? These myeloproliferative neoplasms are many in number, but the problem with these myeloproliferative neoplasms is that the mutation is accelerating the differentiation and maturation of the precursor cell, which means you're going to result in increased cell proliferation, and this is going to happen both in the bone marrow as well as in the periphery. In the periphery, you are going to have increased terminal cells. At the same time, in the bone marrow, you're going to have increased number of cells. That's what we call as hypercellular marrow or increased cellularity of the marrow. But what happens in myelodysplastic syndrome is, I told you, there will be defective proliferation and maturation. Defective proliferation and maturation. Because of that, lot of precursor cells will go for apoptosis. So your periphery will have low number of cells. So typically you will end up with cytopenias. Whereas in the bone marrow, if you see, you are going to result in again increased cellularity, which happens as a compensation for defective maturation. As a compensation for a defective maturation. Here you can see both go hand in hand, the cellularity and the number of cells in the periphery, but here you can see a paradox where the bone marrow is cellular, whereas the number of cells in the periphery is actually less, resulting in cytopenias. So you can see the paradox over here. That's what a myelodysplastic. Apart from that, this defective proliferation will result in dysplastic cells, which means these are abnormal cells in morphology, that you can see that very clearly in the peripheral smear and in the bone marrow biopsy as well. But very clearly here there is not going to be any form of dysplasia whatsoever. So no dysplasia. So these are the differences between a myeloproliferative neoplasm and a myelodysplastic syndrome. And what are these overlap syndromes? Overlap syndromes, to be specific, they are in between MPN and MDS. So they will have features of combined features of both myeloproliferative neoplasm and myelodysplastic syndrome. What is the feature of myeloproliferative neoplasm? They are going to have increased cells in the peripheral smear. Clear? At the same time, bone marrow also will have hypercellularity or increased cellularity in the bone marrow as well. So which means these are typically features of myeloproliferative neoplasm. So what cells typically will increase is the monocyte. We have a lot of mutation that result in increased monocytes, but we really don't know why. But still, monocytes are the ones that are going to increase, and these overlap syndromes are typically going to result in monocytosis. At the same time, they are going to behave like your myelodysplastic syndromes as well, like they are going to produce dysplastic cells also. So the cells in the periphery and the bone marrow that are there, that are increased in number, that is going to show a little bit dysplastic tendency as well. So which means you are having combined features of both myeloproliferative neoplasm as well as a myelodysplastic syndrome, and this is what we put under overlap syndromes. And in overlap syndromes, specifically two things are there. One is called JMML and second one is called CMML. That's called juvenile myelomonocytic leukemia and a chronic myelomonocytic leukemia. Remember, acute myelomonocytic leukemia comes under AML, that is AML M4. We discussed already in the AML section. So it is CMML and JMML. We'll discuss in detail later on. Now, what are the myeloproliferative disorder, myeloproliferative neoplasm? Because there are lots are there in myeloproliferative neoplasms, which we'll discuss in a separate topic, like single lineage dysplasia, multilineage dysplasia, isolated 5q deletion, then excess blasts. So many types of myelodysplastic syndromes are there, which we'll be having a separate discussion in a separate topic. But right now, let us go for the myeloproliferative neoplasms. What are the myeloproliferative neoplasms? Number one, the first and topmost is chronic myeloid leukemia, CML, and second one we have something called a polycythemia vera, and the third one you have something called an essential thrombocythemia, and the fourth one we have something called a primary myelofibrosis, PMF. And apart from that, other things are also there, like for example you have a systemic mastocytosis. We have seen already in the basics of WBC section about the systemic mastocytosis, and you are going to have something called myeloid neoplasm with marrow eosinophilia. Myeloid neoplasm with marrow eosinophilia. And you also have another disorder called chronic neutrophilic leukemia. So this is what we refer to as something called a chronic neutrophilic leukemia. If you ask me about the CML, CML is going to be a result of a mutation called T922, otherwise referred to as this the BCR-ABL translocation mutation, otherwise simply referred to as something called Philadelphia chromosome positivity. And this should be 100% true, which means anything that is not showing the Philadelphia chromosome, we cannot put them under CML. Very, very important point. CML means Philadelphia chromosome should be positive, 100% rule. That's the latest WHO definition of CML, Philadelphia chromosome positivity, one of the important rules to diagnose a CML. Clear? So then these three disorders, these three myeloproliferative disorders, polycythemia vera, essential thrombocythemia, and primary myelofibrosis, is going to show three important type of mutations. One is called JAK2 mutation, second one we have something called CALR mutation, and the third one we have something called CMPL mutations. In this is going to be the rarest form, and this is going to be the most common form, this JAK2 mutations. JAK2 mutations again is of two types. One is called V617F mutation, which is tend to be again the most common among the JAK2 mutations, 90% almost. And you also have another type of mutations called exon 12 mutations. CALR mutations are typically exon 9 mutations, and CMPL mutations are typically codon 515 mutations. So these are the different types of mutations that you are going to encounter. In systemic mastocytosis, we have clearly seen a particular type of mutation called c-KIT mutation, that is typically D816V. So we have seen this mutation already. And about your myeloid neoplasm with marrow eosinophilia, the moment you call eosinophilia, you are going to encounter the PDGF receptor mutation, either a PDGF receptor A or a PDGF receptor B mutation. So it's very, very important. Even you have encountered disease called hypereosinophilic syndrome, where idiopathic eosinophilia for a long time, and that is also due to PDGF receptor mutations. Here the myeloid neoplasm with marrow eosinophilia is also due to PDGF receptor mutation. And chronic neutrophilic leukemia, and this disorder is due to a mutation called CSF3 receptor mutation. Clear? So these are some of the important mutations that you have to know. And you have another disease which is often considered as an overlap syndrome, that's called atypical CML. And I'm not going to discuss anything about this at all, because it's something which is going to be very confusing when I discuss about atypical CML. But still, only the mutation part is very important. It's also with something called SETBP1 mutations, SETBP1. That is what we refer to as something called an atypical CML, SETBP1 mutation. So these are the overall idea. It's very, very, very simple. Myeloproliferative neoplasms are different, and myelodysplastic syndromes are different, and your leukemias are different. All are going to be completely different, at least initially. But one more thing you have to know, I have clearly told that all these are mutations of the myeloid precursor, which means these are acquired and clonal and predominantly precursor cell mutations. Acquired, clonal, precursor cell mutations, most of them. So if that is the case, I told you any neoplasm is going to accumulate mutations over time, which means here also, like in myeloproliferative neoplasm also, there is a myeloid precursor cell mutation, and in myelodysplastic syndrome also there is a precursor cell mutation. In leukemia also there is a precursor cell mutation, which means suppose if the mutations get accumulating over time, even though MPN is initially benign, later on it might become badass. MDS obviously, and some MDS obviously become badass over time. So how they become these badasses is by accumulating mutations over time. So once a critical hit happens at one point of time, there's a lot of probability that these disorders might completely change into an AML, which means they will completely fail to differentiate. Clear? So that is the reason why this can transform into an AML, and this can transform into an AML as well, and even this overlap syndromes can transform into AML as well. So all these disorders can transform into acute myeloid leukemia because they are problems of myeloid precursor cells, so they are going to transform into myelogenous leukemia only. So I told you MDS can transform, and MPN can transform, or an overlap syndrome can transform into an AML, and this type of AML is going to be called as something called as secondary AML, or MDS or MPN related AML, and this is going to have a very, 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 very poor prognosis because they are going to show the worst cytogenetics of AML. Clear? And they are going to be very difficult to treat as well. It's not easy at all to treat these disorders, and you need a separate regimen according to the new guidelines which we have discussed already in AML. So I think you would have got a brief idea on what this myeloproliferative neoplasms and myelodysplastic syndromes are. But with this particular understanding, let us move on to the polycythemia vera. This is the first disease that I'm going to discuss. CML needs a separate discussion in a separate chapter in the next video maybe, but polycythemia vera, let us finish it off. Polycythemia vera means it is just increased RBC mass, which means the RBC count will increase sheerly, but there is no physiological cues, physiological stimulus for increase in this RBC mass, which means it just increases due to mutation in this precursor cell. It can be associated with increase in the number of granulocytes. It can also be associated with increase in the number of platelets, thrombocytes, platelets as well. Clear? So this is because I told you myeloid precursor is not only going to give rise to, this common myeloid protein is not only going to give rise to your like neutrophils or eosinophils, they are going to give rise to granulocytes, they are going to give rise to RBCs, they are going to give rise to platelets also. Clear? So in the polycythemia vera, this is the one that is increasing, but there is a lot of possibility associated granulocyte increase and platelet increase can also happen, because it is a problem of your myeloid precursor. Due to some mutation, the proliferation is increased, or maturation differentiation through RBC lineage increase. Some can spill over towards the platelet and granulocytes also, which means you can result in increased production of this granulocytes and platelets also. So that is the reason why this is also possible, which means 50% of polycythemia vera cases will have increased granulocytes, and 50% of polycythemia vera cases may have thrombocytosis also. As simple as that. So increase in the platelets, if it's going to act as a primary event, then there is a lot of possibility, and this is what we are going to call as something called an essential thrombocythemia. If this is going to happen as a primary thing, that is essential thrombocythemia. If this is going to happen as a primary thing, that is polycythemia vera, or if this is happening as a primary event because of the precursor stem cell problem, this is what we refer to as CML. Clear? If this is a primary problem, it's CML. If this is the primary problem, it's polycythemia vera, and if this is the primary problem, we're going to call as essential thrombocythemia. But it's not a strict rule like that. Since I told you in polycythemia vera itself, you might have increased the number of granulocytes, increased the number of platelets as a spillover to the other lineages. As simple as that. So don't get bogged down by all this, because CML is something very different, which we'll discuss later on. That's why CML is also put under this myeloproliferative disorders, and it's not catascler or acute leukemia. Acute leukemia is a total failure of differentiation, as simple as that. Okay, so now what you mean by erythrocytosis? Let us see the DDs for erythrocytosis, because this polycythemia vera is going to result in erythrocytosis classically. So what do you mean by erythrocytosis? And if we are going to see the DDs for erythrocytosis, if you want to know about the DDs of this erythrocytosis, the first thing, let us construct a table. We can put the features of different disorders, then we can put the erythropoietin here, we can put the plasma volume here, then we can put the RBC mass here, then we can put the saturation over here, and what is the underlying etiology of that particular disorder here. Let us construct it. So first one, you have something called a relative polycythemia. In relative polycythemia, the problem is reduced plasma volume, and this is the one that is going to act as a primary event. Because the plasma volume is reduced, the RBCs tend to be expanded in number. It's a relative thing, it's not an absolute thing. So RBC tends to be increased, but remember, this is only absolutely relative to decrease in the plasma, it's not absolute. So here the saturation tends to be normal, the erythropoietin also tends to be normal. Etiology is going to be severe dehydration, obviously. And there is an entity called stress erythrocytosis, that also is a relative polycythemia only, but anyway, dehydration is what your exam question is going to be on. Number 2, you have something called an absolute polycythemia. In absolute polycythemia, again you have a primary polycythemia and a secondary polycythemia. Primary Again, I will tell you the problem is not anywhere else. It is increase in the RBCs. That is the primary problem here. This increase in the RBC count because of mutation in the precursor myeloid cell, and this is going to result in a secondary problem called suppression of erythropoietin. Obviously, here erythropoietin will be suppressed, and again this is going to be a secondary issue. But your plasma volume will increase because of to accommodate this excess RBCs. At the same time, your saturation will remain normal. There won't be any change. This is the primary polycythemia vera due to. This is polycythemia vera due to JAK2 mutations. Remember, this primary polycythemia, can happen in other diseases like Cushing's syndrome, and use of anabolic steroids by bodybuilders. They can also get a very similar disorder. I mean, you cannot differentiate this from primary polycythemia unless and until you do the mutation analysis. So that is, this closely resembles. That's what I'm trying to tell. One of the important DDs for polycythemia vera, with all the features which I told you, may be seen in this Cushing's syndrome as well as use of anabolic exogenous steroids. Secondary polycythemia, again, you have something called two types. One is called appropriate secondary polycythemia, and second one you have something called an inappropriate secondary polycythemia. What do you mean by an appropriate secondary polycythemia? It is due to low saturation, that is due to hypoxia. This is the main problem here. This is the primary issue here. Because of the low saturation and low oxygen carrying capacity of the blood, you are going to cause an increase in the erythropoietin output, and this is going to act as a secondary event, and this increased erythropoietin is going to increase your RBC count, and this is going to act as a tertiary event here. Clear? And the plasma volume will be normal, and this is the best example for this is patient who are living in high altitude, or patient who are having lung diseases or cardiac disease, pulmonary or cardiac disease, pulmonary and cardiac disease like chronic, like your ILD or COPD patients, or patients who are smoking for a long time, carbon monoxide inhalation for a long time, typically seen in smokers because smoke contains carbon monoxide. All these patients are going to get this polycythemia, which is secondary secondary inappropriate polycythemia. What do you mean secondary inappropriate? Here the primary problem will be increased erythropoietin. Primary problem is going to be increased erythropoietin here. And because of this increased erythropoietin, and it could be secreted by certain malignancies as a paraneoplastic syndrome, and this is going to cause a secondary problem, that is increase in the RBC mass, and so this is going to be a secondary issue for the patient, and whereas the plasma volume and the SpO2 will be normal, the saturation is going to be normal. So where this is going to happen, typically in many paraneoplastic syndrome, especially those with RCC and hepatocellular cancer, renal cell cancer, hepatocellular cancer, and patients who are having polycystic kidney disease may also encounter this kind of particular issue. So these are the differential diagnosis for your dehydration. These are going to be the differential diagnosis for erythrocytosis. Then what is the pathophysiology? Pathophysiology wise, if you ask me, it's quite simple. I told you there are going to be JAK2 receptors. These JAK receptors are tyrosine kinase receptors, where they have tyrosine kinase domains here. These are actually tyrosine kinase receptors where they dimerize the JAK, because JAK means Janus kinase. They are going to dimerize, and once they are activated, you are going to result in downstream signaling, and your cell is going to proliferate. This is a normal thing. Remember, there are two entities are there. So this is a growth factor. If the growth factor binds with this JAK2, and if the JAK dimerizes and all these things happens, it is normal. This is a completely normal physiology. There is no doubt about that. But suppose even without a growth factor, if this downstream signaling is activated, and that is quite abnormal. That's what happens in JAK2 mutations. JAK2 mutations. This can be seen in essential thrombocythemia or primary myeloproliferative, and very commonly seen in your polycythemia vera, JAK2 mutations. That is the problem. Here the problem is the growth factor, the receptor JAK2 is responding even without binding to a growth factor. That's the issue here. Clear? Now, what are going to be the clinical features? Clinical features, typically patient may be asymptomatic, but they usually get symptomatic over time, and the symptoms what they are going to get is something called vasomotor symptoms. What are the vasomotor symptoms they get? The first you can tell is hyperviscosity symptoms. This hyperviscosity is due to increase in the number of cells, typically erythrocytes, but there can be excess thrombocytes as well as your granulocytes in a polycythemia vera patient, but excess viscosity is typically in polycythemia vera is due to erythrocytosis. This can result in shortness of breath, chest X-ray infiltrates, dyspnea, already told you that is shortness of breath. Then you can get dizziness, headache, blurring of vision, tinnitus, lot of things. Tinnitus is also common, blurring of vision, all these things can happen due to hyperviscosity. And next thing, they are also prone for thrombosis. If they ask you what is the reason, pathophysiology for thrombosis, what is the reason for thrombosis? The first reason is many of the patients will have increased platelet count. That is due to thrombocytosis. Second reason is that hyperviscosity. Both are potentially going to increase the thrombosis. But if you ask me the risk factor for developing thrombosis, the single most important risk factor for developing thrombosis, increased WBC count. If the patient is having excess WBC count, this serves as a major risk factor for developing thrombosis in these patients. So the most important thing is they can develop thrombosis in both arterial as well as venous, which means they can cause DVT, they can cause pulmonary embolism, they can cause MI, stroke, TIA, arterial as well as venous thrombosis. Even Budd-Chiari syndrome is possible. And because of this thrombosis, they also result in some peculiar symptoms and syndrome called erythromelalgia. Erythromelalgia. What do you mean by erythromelalgia? It is due to severe burning and severe pain. Along with that, there will be severe redness of the involved area. So this is what we call erythromelalgia. It's a vasomotor symptom, severe pain, severe burning in area. Along with it, that area will be red in color. So this is what we refer to as erythromelalgia. And this is due to thrombus of the microvascular vessels, small vessels, end vessels. So that is the reason for why you get thrombosis, erythromelalgia in polycythemia vera. At the same time, bleeding also can happen. So this is what is very important to understand. Polycythemia vera patient can be a clotter as well as a bleeder. Very important. So why bleeding? Because of one or two reasons are there why bleeding is there. One is, even though platelets are increased, this platelet function is actually reduced. That's the reason they result in mucosal bleeding like epistaxis, easy bruisability, GI bleeding. All these things are common. They actually have mucosal bleeding. That is because the platelets are involved. We'll discuss in some time. So why is that platelets cause mucosal bleeding? Then you have other features apart from this. Other features apart from this, you can get something called pruritus, and you can get peptic ulcer, and this is due to increased histamine release from the basophils. Increased histamine release. At the same time, you can have gout, that is due to excessive uric acid and hyperuricemia due to excessive cell turnover in a myeloproliferative neoplasm. That's it. Apart from that, I didn't tell you this point, any myeloproliferative neoplasm may have associated hepatosplenomegaly. In fact, very common. This hepatosplenomegaly is a very common entity in any myeloproliferative neoplasm. Not only here, even in essential thrombocythemia you see, and primary myelofibrosis also you can see this hepatosplenomegaly. Diagnosis wise, we are going to see the WHO criteria for diagnosis. WHO criteria wise, we have three important criteria. One is based on hemoglobin or hematocrit, and the second one is based on your bone marrow biopsy, and the third one will be based on your JAK2 mutations, whether it's positive or negative. Remember, JAK2 mutations are of two types in general. Almost 95% of the cases will show the characteristic V617F mutations, and approximately 5% of the cases are going to show exon 12 mutation, which means it's nothing like negative polycythemia vera. Somehow the JAK2 mutations must be positive. That's a very important point. And what are these three I told you are major criteria. This hemoglobin, hematocrit criteria, bone marrow biopsy and JAK2 mutation criteria. All these are major criteria by WHO. Hemoglobin and hematocrit tends to differ between males and females. If males, if it's more than 16.5 grams per deciliter of hemoglobin, or if hematocrit more than 49%, or in females if it's more than 16 grams per deciliter of it's more than 48% of hematocrit, is one of the major criteria. And bone marrow biopsy wise, if you see something called tri-lineage hyperplasia. Typically bone marrow will be hypercellular, the cellularity of the bone marrow will be increased, plus they will show something called a characteristic tri-lineage hyperplasia. Tri-lineage hyperplasia. So this is a very important point again. This is a very important exam question. And JAK2 mutations tend to be positive, obviously yes. And there is one minor criteria is also there. Important minor criteria is reduced serum erythropoietin, which is a no-brainer. So this is a minor criteria given by WHO. So among this, if you have all these things, then you can make a diagnosis of polycythemia vera, PV. Then there are a lot of other findings. You can have an excessive uric acid because of high cell turnover, again because you can have excessive LDH, again because of high cell turnover. Patients might be having a reduced ESR, and this one is a very important exam point. Reduced ESR, very very important exam point, because examiners are very fond of it. Anemia will have elevated ESR, whereas polycythemia will have a reduced ESR. At the same time, patients may have excessive serum vitamin B12, and patients may have reduced serum iron. That is because of rapid erythrocyte turnover causing extraction of a lot of iron from the periphery and from the blood, and so that serum iron may be reduced. And elevated lab score, that is leukocyte alkaline phosphatase. Patients may have elevated neutrophils, as I told you already, and elevated basophils. Patient may have elevated platelets. All these things can happen almost in 50% of the patients, which again we have seen all these things. And peripheral, and one more important point to note is the peripheral smear tends to be completely normal, which means except for a very very experienced pathologist seeing a little bit more erythrocytes in one picture, but apart from that it's very difficult to ascertain something, and completely peripheral smear is supposed to be normal in case of a polycythemia vera. Clear? Because this is very important, because peripheral smear of an essential thrombocythemia may be abnormal showing platelet clumps, and peripheral smear of a primary myelofibrosis is definitely abnormal showing a leukoerythroblastic picture. So here the peripheral smear is completely normal. Very important point. Treatment wise, it depends on what are the treatment options you have. The first treatment option is you are going to give for all patients, and what are you going to do for some selected patients. For all patients, I can use a low dose aspirin and low dose, like 75 milligram per day, which reduces the thrombotic tendency, and patients can go for phlebotomy. Typically you have a target hematocrit for phlebotomy. Target hematocrit for phlebotomy for a male is less than 45%. For a female it's going to be, depending on non-pregnant or pregnant. If it's a non-pregnant women, it is going to be less than 42%, or if it's a pregnant woman, it is going to be less than 37%. Clear? So selected people, who are the selected people? Especially for certain people, we are going to use drugs, selective drugs. What are the selective drugs? You can use hydroxyurea. Any one only we are going to use, or we are going to use a drug called ruxolitinib, or we are going to use a drug called pegylated interferon alpha. And a lot of supportive treatment are also there. Supportive treatment like you can give uric acid lowering agents like allopurinol for patients who are having gout, or you can use pruritus antihistaminics for patients who are having peptic ulcers. You can use H2 blockers or PPIs. So these are supportive. I'm not going to talk about them. But anyways, so these are the drugs that are available. Hydroxyurea is the standard drug. Remember, this is the first line for many things, because it's very superior drug in myeloproliferative neoplasms really. Ruxolitinib is a JAK1 and 2 inhibitor. Remember, JAK is the problem here, mutated one. So if you inhibit that, probably you might help these patients. So ruxolitinib can be used only if there is intolerance to hydroxyurea, or if there is reduced response to hydroxyurea. Reduced response to hydroxyurea. So in those conditions, you can use ruxolitinib, otherwise there is no role. Pegylated interferon alpha, typically we prefer in either a very young patient or a pregnant patient. I think clinically the most suitable thing is a pregnant patient who cannot use either ruxolitinib or hydroxyurea. In those patients, you can use a pegylated interferon alpha. So apart from that, overall, what are the indications for these drugs? That's what I want. What are the indications for these drugs, any of these drugs to use in the first place? The first topmost indication is going to be increased thrombotic risk. Increased thrombotic risk is something very simple. Only two patients are at increased thrombotic risk. One is if the patient is at elderly age more than 60 years, or patient is having a prior history of thrombosis already. Second one, if there is a very high platelet count, typically if it's more than 15 lakhs, definitely you have to give any of these drugs, cytoreductive drugs. So suppose if the target hematocrit cannot be reached, is not reached by your drugs, like by phlebotomy, then this also becomes an indication to start the drugs. So these are some of the important treatment aspects that you might needing to know. And this, since is I told you already, this can transform into other entities. Like for example, if you have polycythemia vera, it can either transform into a primary myelofibrosis or it can transform into a secondary AML as well. What is the risk? The risk of getting transformed to a primary myelofibrosis is approximately maybe 10 to 20%. 10 to 20%, and it typically happens after 10 years, very commonly. And the median survival in polycythemia vera itself is 13.5 years. It's more than 10 years. So, which means the time they transform into your PMF or AML, they die. That's the idea. And secondary AML risk is approximately around 2 to 5%, but still lower number in some studies, but 2 to 5% is what your risk of transforming to secondary AML. Remember, age and WBC count are the most important prognostic factors. More the age, more poorer is the prognosis, lesser is the survival. Similarly, more the WBC count, poor is the prognosis and lesser will be survival. So age, WBC count forms the major prognostic factors in case of a polycythemia vera. Then you have something called essential thrombocythemia. Essential thrombocythemia, why is, again it's clonal proliferative disorder, primary disorder that is causing excessive thrombocytosis, excessive platelet production and dissemination into the periphery. But it's not due to some underlying cause. It's not due to some reactive increase in the platelets. So let us see. Whenever you think about thrombocytosis, remember a thrombocytosis. It can be either a primary thrombocytosis or it could be a secondary thrombocytosis called as a reactive thrombocytosis. Primary happens due to problem in the myeloid progenitor. It's due to an issue in the myeloid progenitor. Problem is the myeloid progenitor, which is differentiating into increased differentiation to platelets and megakaryocytes. Increased differentiation to megakaryocytes and platelets. Megakaryocytes and platelets. What are the things that are going to form these disorders? The first one, obviously, it's essential thrombocythemia. It can happen with a lot of other myeloproliferative neoplasms, including primary myelofibrosis and polycythemia vera. Apart from that, it can also happen in certain varieties of MDS. Yes or no? Especially if you have 5q deletion. I'll tell you there. You might ask me, sir, you've already told there will be cytopenias with MDS, but I'm not denying the fact there will be cytopenia, but sometimes certain variants of MDS, certain types of MDS like MDS with 5q deletion may have anemia as a cytopenia, but thrombocytosis may also be there, and it will be atypical megakaryocytes. That's what is going to happen, and let me discuss about that in MDS separately, but don't get confused by the fact I'm introducing MDS here. So that's what the disclaimer is telling. So it can have a cytopenia, and you have a hypercellular marrow. Along with that, you might have a high platelet count also as a part of it. So MDS can happen with that. So reactive thrombocytosis typically happens in inflammatory states. Reactive thrombocytosis typically happens in inflammatory states like rheumatoid arthritis, IBD, and a lot of other states like vasculitis. So many conditions you might have a reactive thrombocytosis. Then you might have in infection, a lot of infections can cause thrombocytosis, then acute bleeding where the platelets will be released from the spleen as a reactive measure. And obviously after splenectomy, because you know that spleen stores 1/3 of the platelets. A lot of platelets are sequestered in the spleen. Once you remove the spleen, they cannot be sequestered, and that will be circulating in the blood, causing reactive thrombocytosis. And a lot of neoplasms like Hodgkin lymphoma itself can cause reactive thrombocytosis, and iron deficiency, very important point. Iron deficiency also can cause reactive thrombocytosis. Remember, reactive is actually quite more common than your primary thrombocytosis. Reactive is very common, very far more common than your primary thrombocytosis. Clear? So these are some of the DDs for thrombocytosis. What are the clinical features that are going to see? It's going to absolutely resemble polycythemia vera in many instances, which means they can result in thrombosis, and it can also result in erythromelalgia, that is again due to small microvascular thrombosis, erythromelalgia. It can result in bleeding as well. Here the bleeding is due to one more reason, and very high platelets may sequester the von Willebrand factor, and that is something called as acquired von Willebrand disease, which means I told you platelets will have this GP1B, which is going to bind with the von Willebrand factor, and a lot of platelets like this are going to capture a lot of von Willebrand factor. If you have so much of platelets like this, they are going to capture a lot of von Willebrand factor, and which means in the blood, in the intravascular compartment, the free von Willebrand factor levels will be very much less. That is because a lot of things are already captured and sequestered along with the platelets. So this can result in a peculiar type of disease called an acquired von Willebrand disease. That might also be the reason for bleeding, especially this happens if the platelet counts are extremely high, like more than 15 lakhs. This is also one mechanism where you can get a bleeding. Then apart from that, pruritus, your migraine, mild splenomegaly, all these things are very similar to what you see in polycythemia vera, so I'm not going to discuss again and again. Then diagnosis wise, remember, very important point is there are certain diagnostic points, but you have to rule out the other myeloproliferative neoplasm. It's a very important thing. So typically in a peripheral smear, you are going to see a large hypogranular platelets, large and hypogranular platelets. Remember, and they form a lot of clumps generally. You can see a lot of platelet clumps. And remember, platelet clumps can form in many conditions, even in with EDTA use you can see, because whenever you use EDTA as an anticoagulant for collecting blood, and if you see platelet clumps, the pathology itself will give, it's not abnormal, you have used EDTA and you are going to see the platelet clumps. If the pathologist suspects something else, he will ask you to repeat the sample with another anticoagulant, not to use EDTA. Some patients might react to EDTA and they may develop platelet clumps. So this is not really abnormal in all the cases. It's a very common entity, in fact, in pathology thing. But anyway, clumping is very common. But these large hypogranular platelets are definitely abnormal, that you can see in the peripheral smear. At the same time, in the bone marrow, you are going to see megakaryocyte hyperplasia. You can see a lot of megakaryocytes in very active stage forming clusters of platelets, and that's what we refer to as megakaryocyte hyperplasia. And this is very important. And what is the importance? Why you need a bone marrow? Why you need a bone marrow? Because in polycythemia vera, we really don't need a bone marrow. If you have a JAK2 mutation with excessive hemoglobin and hematocrit and low erythropoietin, it's enough to diagnose polycythemia vera. You really don't need bone marrow to be done all the time. But here you need a bone marrow for sure. Why? Because one thing, you have to rule out iron deficiency anemia, because it's a very, very important cause of reactive thrombosis. Even it can go up to 10, 12 lakhs sometimes. So because you have to see the bone marrow iron stores by doing bone marrow biopsy. This is not the only thing, because there is another disease called PMF, which like primary myelofibrosis especially, which can have increased platelet counts. So that is what we refer to as something called pre-PMF. Rule out this pre-PMF also. This pre-PMF is pre-primary myelofibrosis stage of PMF, where again the patient will have increased platelets. But remember, as I told you, bone marrow iron stores will be decreased in your iron deficiency. Similarly, you have a clue for this pre-PMF. What will be the clue for this pre-PMF is that your megakaryocytes will be atypical. Atypical megakaryocytes will be there. But remember, very little fibrosis will be there. It's a pre-PMF stage. It's not an actual PMF stage, it's a pre-PMF stage. So you won't see that much of fibrosis. but this presence of atypical megakaryocytes along with thrombocytosis should give you an idea about this probable pre-PMF stage of a PMF. That's called pre-primary myelofibrosis stage of a primary myelofibrosis. So these two things are very, very important to rule out. And very importantly, you have to rule out MDS also, because I told you certain varieties of MDS associated with 5q deletion may also have thrombocytosis and splenomegaly. So very important, you have to rule out MDS, myelodysplastic syndrome. Clear? So then certain mutations, mutation analysis. Mutation analysis wise, there are 3 mutations that you can see. One is called a JAK2V617F mutation, which is typically seen in 60 to 65% of the cases. And you can have this CALR mutations, which can be seen in approximately 20 to 25% of the cases. And you can see the CMPL mutations in 5% of the cases. Or it can be completely negative for mutations in 5 to 10% of the cases. Triple negative in 5 to 10% case, that is also possible. With this, I am going to give a special reference to the CMPL mutations. What happens in CMPL mutations? Remember, for that you have to understand one important thing. You have a lot of platelets, and these platelets are going to have this CMPL receptors. These are CMPL receptors, and let us assume you have a lot of thrombopoietin circulating, which is going to stimulate the megakaryocytes to produce platelets. And what's going to happen is this CMPL is going to consume this, TPO. So which means whenever there is defective CMPL, your TPO will increase and platelet count will increase. So let us assume in normal state. In normal physiology, what happens? So let us assume there is increased platelets. The moment you have increased platelets, there will be increased consumption of TPO, thrombopoietin by this MPL receptors. This will result in reduced circulating thrombopoietin levels. This will result in reduced platelet in return. This is a negative feedback. So this is a feedback. This is a normal thing. Similarly, when you have a low platelet, let us assume, then you have a reduced consumption of TPO by this CMPL receptors on the platelets, because your total platelet itself is low, which will result in increased circulating TPO causing increased platelet as a response. So this is again a negative feedback. It's a feedback mechanism. But what happens here is, if CMPL is defective, for example, in any of these conditions, CMPL is defective, you cannot consume this TPO, and the TPO levels automatically increase. That's going to result in thrombocytosis, and that is how the CMPL mutation is going to result in thrombocytosis. Remember, it is very different in JAK2 and CALR mutation. This principle doesn't apply there, but I'm telling how you can get a thrombocytosis in CMPL mutations. Clear? Cool. Now, at the same time, remember, as per WHO guidelines, you have to rule out other myeloproliferative neoplasms, as well as MDS. Typically, which means you have to rule out CML, you have to rule out polycythemia vera, and you have to rule out primary myelofibrosis. Very, very important. Very, very, very important. And rule out MDS also, because it can also produce thrombocytosis, very similar to what you see in essential thrombocythemia. Now, let us see for the treatment aspect. Treatment you can divide into something called a low risk, and second one is called a high risk cases. Depending on that, you can do the treatment. In high risk patient means age more than 60, history of thrombosis, same thing what you saw in polycythemia vera. Or patient is having a platelet count very, very high, more than 15 lakhs. So if these are there, I'm going to use aspirin plus I'm going to use cytoreduction. Typical cytoreduction drug I'm going to use is hydroxyurea. That's it, nothing else. Or you can use interferon alpha. Here ruxolitinib will not be that effective. Hydroxyurea, or I can use interferon alpha, pegylated interferon alpha, if suppose the patient is a pregnant woman or maybe very young patient. So I'm going to prefer only hydroxyurea for this purpose. Very important. Along with aspirin and cytoreduction, both has to be done. If low risk, if none of these factors which I told you are there, age is less than 60, history of thrombosis is not there, and platelet also less than 15 lakhs, then all three are not there, then you can go for lowest treatment. Only thing is optional aspirin. No need of any cytoreduction, you need only optional aspirin treatment. Why that too optional is only if the patient is having any vasomotor symptoms. Only the patient is having vasomotor symptoms, you can use aspirin, otherwise there is no need for using any aspirin in these patients as well, but it's optional, but many patients we do give. Treatment wise, there is one more drug is there that came as another option for cytoreduction, that is called anagrelide. Anagrelide is said to be phosphodiesterase 2 inhibitor, which can reduce the maturation of megakaryocyte to platelets. That's the mechanism of action of anagrelide, but it is found to be inferior, even though it's created a huge hype during that time, but it was clearly proven by many trials to be inferior to hydroxyurea. So currently we do prefer only hydroxyurea. Similarly, prognosis wise, low risk patients have normal survival rates, which means high risk patients have a little bit reduced survival, but low risk patients typically they do have a normal survival or a normal lifetime if he's a low risk patient. So there is no difference from the general population, but high risk may have a little bit of reduced life expectancy. Now, the risk of transformation to other myeloid structures, that's also we have to know. So we told for polycythemia vera, but currently we can see essential thrombocythemia. Essential thrombocythemia also can transform into a primary myelofibrosis, or it can transform into a secondary AML. And what's going to be the risk? The risk of transformation to primary myelofibrosis is approximately 20%, a little bit high. And the risk of transformation to AML, actually it's quite less, but it will be less than 2% usually. The number is even lower in certain trials, I told you. So this is the risk of transformation of essential thrombocytosis to other disorders like PMF and AML. And now we can see another important disorder called primary myelofibrosis. Let us see the pathophysiology of primary myelofibrosis. Primary myelofibrosis, you have fibrosis of the bone, so like fibrosis of the marrow, so where the marrow is going to, yellow means fibrosis here. So since there is a fibrosis of the marrow, your whatever marrow that is remaining, they are trying their best. So whatever marrow that is remaining, they are trying their best to increase the erythropoiesis, but they are trying their best to push the cells outside. So there are a lot of problems in pushing the cells outside. While pushing the cells outside, many things are dying in the bone marrow itself, leading to something called ineffective erythropoiesis, because they cannot push through this fibrous tissue. So plus at the same time, majority of the marrow has been replaced with fibrous tissue. So this is also one reason why you will get ineffective erythropoiesis, which means you might result in cytopenias. Instead of having, you might result in cytopenias, like typically anemia. Instead of having increased cells in the periphery, like what you see in other myeloproliferative neoplasms. But remember, this is proliferation. Why? Because due to a lot of other reasons I'm telling you, it's a proliferative disorder only, but cytopenias are possible. And at the same time, these cells that are moving out, of this fibrous tissue may develop an abnormal shape. Abnormal shape will be there, and best example for this abnormal shape of the cells is what you're going to get is a teardrop RBC. Teardrop RBC. This is one example why you get an abnormal shape. So teardrop RBC, they move out and come out, so teardrop RBC are very common. At the same time, this ineffective erythropoiesis also further stimulates the marrow, because there's a cytopenia that is also going to further stimulate the marrow more and more and more. So the remaining areas will go for, they go mad, isn't it? So they have to increase the production. So they will try to increase the production, but nothing is coming out. So what will happen is, so since they are trying to increase the production, there is no other option. The precursor cells will be released. Precursor cells will start getting released. Like for example, a myelocyte should not be released basically. Only a mature neutrophil should be released, or a band form may be released from temporarily. And nucleated RBC will be released in the erythroblastic stage itself, or in the reticulocyte stage itself. It will be released in the precursor stage itself, and that is what we refer to as a nucleated RBC. In the nucleated RBC stage itself, it will be released in a normoblast or a erythroblastic stage. So you will be seeing a lot of myelocytes, NRBCs in the precursor stages. but this is in an attempt to somehow like compensate for the like ineffective erythropoiesis. And at the same time, this ineffective erythropoiesis also results in extramedullary hematopoiesis. Since they result in extramedullary hematopoiesis, this extramedullary hematopoiesis means the most important organ that's going to go for extramedullary hematopoiesis is spleen. That is the reason they're going to go for massive splenomegaly. Remember, the main reason why they go for splenomegaly in case of your polycythemia vera and essential thrombocytosis is because of sequestration of this excessively produced cells. But in primary myelofibrosis, the main reason for why you get this such a massive splenomegaly is extramedullary hematopoiesis. This extramedullary hematopoiesis, if it's happened in the paraspinal regions, I told you already this in thalassemia, where you can get cord compression and paraplegia also. That is also possible. And this extramedullary hematopoiesis can happen in the lungs also, and which can result in pleural effusions and all. All these things are possible. And you can see the bone marrow is actually working hard. You can see now bone marrow is actually a workaholic, which means it's trying to push outside but nothing is going out, and it's trying harder and harder and harder, and somehow it is managing. Since this workaholic means there are very high cell turnover, lot of cells are being produced but they are not getting out. So the cell turnover is very high, and this is going to increase the LDH levels, and this is also going to cause a lot of fatigue, weight loss, night sweats, B symptoms. Yes. Clear? The reason for B symptoms is high cell turnover only, as simple as that. So anyway, so they might get this B symptoms, this fatigue, weight loss and night sweats also. So these are the reasons why you might result in a, and I mean I also told you about the clinical features of this myelofibrosis along with it. So these are some of the important things that you have to note about the myelofibrosis. Now after noting about all these things, now let us see what are the etiologies of this myelofibrosis. So if you take myelofibrosis, I'm not talking about the primary myelofibrosis. When you take myelofibrosis as an entity, it could be either a primary myelofibrosis or it could be other conditions causing myelofibrosis. Primary myelofibrosis, in the sense, it's generally due to your PMF, which can be primary itself. Primarily, it can happen, or it can happen after a post polycythemia vera or essential thrombocythemia, which is typically we are going to call something as a spent phase, which I told you already, where the bone marrow is tired and exhausted, spent out, no more cells, and it's replaced by fatty tissue, so fatty and fibrous tissue. So that's what we call the spent phase. And other disorders that which is going to produce your myelofibrosis, typically I can tell CML can produce, AML can produce. Do you remember the M7 variant of AML, megakaryocytic excessive PDGF? We have already seen the AML. This also can produce myelofibrosis. You can get in ALL, you can get in myelodysplastic syndrome, or you can get in a lot of solid cancers, solid organ cancers like breast and prostate. You might also get with certain conditions like autoimmune disorders like SLE, and collagen, other connective tissue disorders also can produce myelofibrosis. And at the same time, you can also get in a lot of toxins, especially benzene, very important drug. Whenever we talk about hematological malignancy, benzene always comes. Then granulomatous conditions like TB and sarcoidosis can produce myelofibrosis, and deposition disease like Gaucher's. All these things can produce myelofibrosis. A lot of conditions can produce myelofibrosis, but anyway, so I believe that AML M7 is the most important here, because this is a multiple times asked question, because it's due to M7 is due to high PDGF production. Clear? So that's what is going to be produced on PMF, primary myelofibrosis. So we already seen the clinical picture in the bone diagram which I have drawn. So let us go for the diagnostic evaluation. Diagnostic evaluation wise, what will be the hemoglobin you will be seeing, what will be the WBC you will be seeing? Very simple. Typically you will see anemia, and WBCs and platelets will be variable. WBCs and platelets will be highly variable. But one important point you should note is that you might have a thrombocytosis in a stage called a pre-PMF stage, where you won't have anemia, where you won't have any problem with the other lineage, only thrombocytosis, probably with atypical megakaryocytes in the bone marrow. That's it. So that's the only thing that you will see in a pre-PMF stage. At the same time, you might have something called a leukoerythroblastic picture. leukoerythroblastic picture. So leukoerythroblastic picture, I told you will have teardrop cells. Along with that, why it's called leukoerythroblastic? Leukoerythroblastic means, blastic means precursor cells, which precursors of what? Leukocytes and erythrocytes. That's what we called as leukoerythroblastic picture, along with the teardrop cells. Plus, you're going to see a lot of precursor cells. Precursors will be increased in the blood. So this is what we called as leukoerythroblastic picture. And massive splenomegaly is the key. Majority patients will have massive splenomegaly. That itself will tell you this is the primary myelofibrosis. And you know, like this platelets, I told you increase, but they'll be large and abnormal. You'll see a large abnormal platelets. Again, that's very important. Clear? And bone marrow, because these are the peripheral smear findings till now, which I've told you, anemia, WBC, all these are peripheral smear findings. And what will be the bone marrow findings? Bone marrow, typically one important point they will be asking is, you're going to get a dry tap, there is no other option, you have to go for the biopsy, because aspiration is going to yield a dry tap for sure. That's due to fibrosis. You're not going to get anything because it's a fibrous tissue. And you have to do a biopsy. In biopsy, you're going to see fibrosis. That's what you're going to see. But in this itself, you can split it into two. One is called a pre-PMF stage, and second one is called late fibrosis stage. What you see in a pre-PMF stage? In pre-PMF stage, you won't see anything. You will see only, like atypical megakaryocytes. Atypical megakaryocytes with megakaryocytic proliferation. This is the first lineage to be affected. Atypical megakaryocytes with increased megakaryocyte proliferation. Fine. Plus, you will see reticulin deposition, but it will be only grade 1. You will see only grade 1 reticulin fibrosis. Plus, you will have increased marrow cellularity also. Overall, this is what we call pre-PMF stage. And in late fibrosis stage, you will be seeing grade 3 or 4 reticulin deposition, grade 2, 3 marked, grade 2, 3 or 4 reticulin fibrosis or reticulin deposition, and you will have a very, very, very marked megakaryocyte atypia, atypical megakaryocytes, megakaryocyte atypia. Clear? It's always important you have to rule out other myeloproliferative neoplasms, and other cause of myelofibrosis, because it could be a post ET or PV myelofibrosis. Anyway, so use other causes of myeloproliferative neoplasms and myelofibrosis. Fine. So now, what are the mutations that you can see? Mutations that you can typically see in these patients are your JAK2 V617F mutations, which is typically seen in 45 to 60% of the patients, and your CALR mutations, again you're going to see in 30 to 40% of the patients, and finally you have your MPL mutations that is seen in 7 to 10% of the patients, or it can be triple negative in 2% also. So that is also possible. So these are the mutations you see, and again I told you, in any myeloproliferative neoplasm, your most common mutation is going to be JAK2 V617F. And remember, the patient should not have BCR-ABL translocation, Philadelphia chromosome, all these things. As I told you, you have to rule out other myeloproliferative neoplasms and your myelodysplastic syndromes also. That's also very important to rule out. Treatment-wise, remember, again, treatment depends on a lot of factors. Like generally, if the patient has asymptomatic, no symptoms, or if the patient is having no anemia, no poor prognostic factors. No poor prognostic factors. Clear? And asymptomatic means you don't need any treatment. You can just observe this patient safely. But the moment I tell poor prognostic factors, you have to know what are the poor prognostic factors as well. So poor prognostic factors in primary myelofibrosis include the 5 important factors. This is the thing that is used in scoring system for primary myelofibrosis. What are the 5 ones? One is age more than 65, elderly. Second one, if the patient is having constitutional symptoms like fever, weight loss, night sweat. Second one, if the blasts, I'm not talking about in the bone marrow, the blood blasts here, if it's more than 1%. then if the WBC count is more than 25,000, or if the hemoglobin is less than 10 grams per deciliter. Clear? So all of these are going to have 1 point for each, and if the patient is having 0 points, then we call it as low risk. If the patient is having 1 to 2 points, we call it as intermediate risk. Anything more than or equal to 3 points, we are going to call it as high risk. So this is the poor prognostic factors, and again you are going to do no treatment in these patients. Suppose if the patient is having symptoms, or suppose if the patient is having some poor prognostic factors or presence of poor prognostic factors, definitely you have to use some treatment. What are the treatment you have to use? Number one, currently we can prefer ruxolitinib. Ruxolitinib actually reduces the splenomegaly, reduces the leukoerythroblastic picture, reduces fibrosis, and even it is known to increase the survival as well, overall survival also. So ruxolitinib, we already saw, it's a JAK1/2 inhibitor. Then you have other JAK1/2 inhibitors that are also can be used. What are the other JAK1/2 inhibitors? We have something called a pacritinib. Then you have something called a momelotinib. Momelo, ME. Then you also have something called a fedratinib. Or all these are in line for approval, but still can be used. But remember, ruxolitinib is already approved for use in PMF. It's clearly proven to increase the survival in these patients. Number 3, you can use, if this cannot be used, then you can use other drugs like androgens and immunomodulators like lenalidomide. Androgens can be used, or you can use other drugs like lenalidomide. If the WBC counts are very high, then you can prefer using hydroxyurea also for cytoreduction. Typically this is used in case of significant leukocytosis or significant thrombocytosis. Suppose apart from that, like alternative treatment, you can use splenectomy. If the patient is having transfusion dependent anemia, obviously that's one of the main reasons why you do splenectomy in many conditions. So if the patient is having transfusion dependent anemia, or if the patient is having massive splenomegaly causing severe pain, that is due to splenic infarcts. Most of the time they cause abdominal pain, left hypochondrial pain. If that is the case, or if the refractory symptoms, in those conditions you can try doing a splenectomy. Apart from that, again supportive treatment for severe anemia, you can use erythroid stimulating agents like epoetin alpha, darbepoetin beta, or pegylated methoxyepoetin beta. All these erythroid stimulating agents can be used if there is an anemia plus erythropoietin levels are less than 500. In those conditions you can use this. Apart from that, there is no need to use. But remember, one important point here is, I told you can use ESAs, but ESAs will worsen splenomegaly. That's a very important point. And pain is having problems due to splenomegaly, do not give this drug. Very important point. It can worsen the splenomegaly in a patient with primary myelofibrosis. Not in other conditions. In this condition, it can worsen the splenomegaly. And apart from that, you can go for allogeneic hematopoietic stem cell transplant also, especially if the patient is having patients are younger with a lot of poor prognostic factors, very high risk, then you can even try a allogeneic hematopoietic stem cell transplantation. Finally, in exam, what will be the clues towards diagnosis of all these disorders? Clues towards diagnosis of all these disorders, these patients will have increased RBCs as a primary entity, and patients may have thrombosis, erythromelalgia, and bleeding. Erythromelalgia, or the patient may be having history of bleeding also, and definitely they will give JAK2 positive mutations, surely. And if the patient is having essential thrombocytosis, definitely the examiner will give you very high platelet levels for sure. Along with that, patients may have increased RBC or granulocyte, that I am not going to talk here. And again, patients will have very, very similar symptoms, very important. At the same time, the patients may show bleeding, and remember, any mutation can be positive here, JAK2, CALR, or CMPL. But examiner typically goes towards the CMPL, I don't know why. This is what examiner goes towards as far as I've seen the previous papers, but any mutation can positive. But remember please, in this itself, JAK2 is commoner actually. even in essential thrombocytosis. But remember, here the peripheral smear will be completely normal and bone marrow will show only trilineage hyperplasia. Trilineage hyperplasia. But here peripheral smear will not be normal. We will be seeing large hypogranular platelets. Hypogranular platelets. And here you will see megakaryocyte hyperplasia. Lot of active megakaryocytes you can see in the bone marrow. That anyway, it's not typical trilineage hyperplasia you will see in essential thrombocythemia. But here it's very easy to diagnose PMF in general. Usually it will be a elderly patient who's coming with anemia, and they will have this little bit increased MCV. That is very important because of the precursor cells are coming which are very big, so they might overall increase the MCV of the patient. At the same time, they might have increased total count, even though it's variable. This is a common picture in exam, and they usually will have increased platelet count, and this also a picture. And definitely they'll give peripheral smear typical of a leukoerythroblastic reaction. Leukoerythroblastic picture, very important again. And in bone marrow you will see fibrosis. Fibrosis, the worst affected lineage will be the megakaryocyte lineage. Megakaryocyte atypia will be seen, which means atypical megakaryocytes will be seen, and this is the worst affected lineage in PMF. And mutation wise, again you can see either a JAK2, CALR or CMPL. Here I cannot predict, they can give any mutation. But even here, JAK2 is the most common mutation. So this is what you're going to get. And remember, patients will have massive splenomegaly. That, very important point. Massive splenomegaly. Very important point, the examiner likes this. So this is very, very important picture. These are the clinical pictures that you get in exam if your examiner wants to diagnose one of these disorders. Let us see some images here. And you can, as I show you, that this is a very typical picture of an erythromelalgia. And this is a very important image that you see in a polycythemia vera. You'll not get an exam, but just I'm showing, you can see all the lineages. Every single lineage cell is showing hyperplasia. This is what we refer to as something called a trilineage hyperplasia. Fine. Trilineage hyperplasia. Then you can see huge platelet clumps. This you can see with EDTA as anticoagulant itself, but here you can see this is a very large, this much big platelets generally don't see, and they are hypogranular also. So this typically goes towards, in this context of thrombus or bleeding, it is essential thrombocytosis. Remember, EDTA associated platelet clumps will have thrombocytopenia. Whereas if a platelet clumps are due to essential thrombocythemia, it will be high platelet count. So a lot of difference are there. So you can see this is the bone marrow aspiration, a biopsy report in an essential thrombocythemia, where you can see very, very active megakaryocyte, which is multi-lobe megakaryocyte here. Multi-lobe nucleus in megakaryocyte, very active, differentiating. That's why it's multi-lobed, and you can see a lot of clusters of platelets that is being formed from a megakaryocyte, very active megakaryocytic proliferation. And you can see this is a leukoerythroblastic picture, where you can see these are the classic teardrop RBCs. You can see here, and you can see a lot of nucleated RBCs also. These are NRBCs, and this one is the myelocyte, which means you are seeing precursors. These are all precursor cells of leukocytes and RBCs, leukoerythroblastic, and you are seeing a teardrop picture, confirms leukoerythroblastic picture. So this is nothing but a leukoerythroblastic reaction or picture. Then you can see your reticulin deposition. This is a reticulin stain. This is reticulin stain. You can see this black things over here. These are all fibrosis and reticulin deposition. So if they give you this kind of picture, it typically goes towards primary myelofibrosis. So these are the important images, but I believe that the most important image you might get of all is this one. This is the most important leukoerythroblastic picture. Maybe this is the second image that you have to consider, erythromelalgia, and probably this is the third image that might go towards your essential thrombocythemia. So these are the important images that you have to see for exam. And apart from that, I think we are concluding the part 1 of the myeloproliferative neoplasm, and I think in the next section we will be dealing on chronic myeloid leukemia, and we can also deal the other, some 2 small myeloproliferative neoplasms are that is chronic eosinophilic leukemia and chronic neutrophilic leukemia. Cut.